We all know that color vision is a function of the retinal cones, and each cone responds to different wavelengths. I'm not going to read slides to everybody. Everybody can read the slides. And just remembering that we have the three primary colors of red, green, and blue. And I'm almost positive for docs that want access to this presentation, the guys at KONAN will get it to you if you want it later on. I'm pretty sure it's being recorded. So our basic review on normal color vision, the three primary colors, okay, all basic stuff for us. Now, let's get serious. So we're going to talk about the neural response of the visual pathway. So we're going to pivot real quick and let's start getting serious. So let's look at what's going on here in the neural response of the visual pathway. So we've got some stimulus coming into the eyeball, some light stimulus, the retina stimulated, an action potential is created. It's kind of electrical stuff going on. And you can see in the diagram the visual pathway as the information is coming along the optic nerve, branching off, going into the lateral geniculate nucleus here, and then crisscrossing and going all the way back to the visual cortex. So again, a review of our neuroanatomy. And this is important enough to actually, call out the circuitry for color coding begins with the parallel ganglion cell systems. And it's almost like one of our friendly college professors where you'd be lecturing and the guy would say, or the lady would say, hey, this is going to be a test question, and everybody would stop talking and then take notes about the test question. If I actually read a slide to you, man, that's like one of our professors saying, this is a test question. That's how important it is. So the review of our neural response of the visual pathway and our parallel ganglion cell systems. And I remember, God, I'm dating myself, I remember when these terms were new. When I was in optometry school, I think as a fourth-year student was the first time I ever heard the words magnocellular pathway or magnocellular division. It was when the first FDT instrument came out and they started talking about evaluating the magnocellular division, and that was all new stuff back then. Well, now here we are 30 years fast forward, and we have a much, much better understanding of these parallel ganglion cell systems and how they're oriented in a retinotopographic mode, where they're all like, it's like cable. So if you can think of the visual pathway, so you got the eyeballs here, the impulses, the neural signals are coming back along the visual pathway. So you've got almost like a telephone cable where you've got the red wire, the blue wire, the green wire, and then they're twisted around in that coaxial form. Think of our visual pathway like that. And you could almost say the parvocellular division is the red wire, the magnocellular is the green wire, the coniocellular is the blue wire. So just think of it like that. And all this stuff, everything we're going to talk about kind of flows from this. You've got to understand this part is so important. So we've got our parvocellular vision, which transmits the red-green color vision. So you've got high-resolution achromatic vision, the red-green, and you've got a bunch of fibers, a high degree of redundancy. So it takes quite a bit of damage before anything shows up abnormal and that's being manipulated or transmitted by this parvocellular division. We've got the magnocellular division, which we are so in tune to now because of all our glaucoma stuff. Most people that get glaucoma, we see that the magnocellular division can be damaged way before the others, and a lot of our testing now is oriented towards trying to detect damage in the magnocellular division. For the sense of this lecture, the magnocellular division does not transmit any color signals. So it's all achromatic vision there, so we don't have to really worry about that too much as far as color vision goes. And here in the coniocellular division, this is the most critical. And when I found this out after reading this article here in this neuroradiology journal, it's like, wow, everything made so much sense. And the blue-yellow is transmitted in the coniocellular. So we've got our parvocellular, magnocellular, coniocellular, the three parallel ganglion cell systems. And these are organized kind of again in that cable, and then the cable runs to the lateral geniculate nucleus, and then the wiring, the pathways, the linkages, whatever you want to describe it, is then reorganized in the lateral geniculate nucleus, and then those axons are projected to the visual cortex where everything is processed, and then the visual cortex uses all kind of neural circuits to process color and form and all this other stuff. So this is really, really important that we kind of do our review on visual pathway neural response. We've got the receptors in the eyeball, that start the whole thing. We've got the transmitters, which is basically the visual pathway and the bulk of the brain, and then the visual cortex at the end, kind of a beginning, a middle, and an end as far as transmitting this neural response. And really, really cool if you see this cross section. So this is a cross section of the lateral geniculate nucleus where it says MM, that's the magnocellular, PPPP is parvocellular. So you see these dark bands that are stained here? So that's the parvocellular pathway, here, 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 and here. If you see my cursor, then the magnocellular here and here. Between these dark layers, you see this white kind of ground-looking substance right here. That is the coniocellular pathway right there. This white band, this white band, that white band there. The little tiny thin bands between these thick ones, that's the coniocellular. That's what's transmitting the blue-yellow. And it's only 2% of the cones that are transmitting that information, so you have practically no redundancy, and you'll see as we go why it's so important, so that if there's any damage to the visual pathway, well, I could lose 50% of my red cones and the red-green fibers, the axons that are connected to them, and I probably could still see red. If I lose a few fibers here, it's going to affect this totally. And so you'll see why this is so important, why only 2% of the cones are responsible for blue-yellow, and why we get these blue-yellow defects when we have ocular pathology. So here's our review: neural response, receptors, transmitters, primary visual cortex. So this is how normal color vision should work. So normal color vision here, normal color vision being received by the eye, transmitted through the brain to the primary visual cortex and processed so that we can perceive color. That's how it's supposed to work, okay? That's our review. Now, let's talk about what we're all doing, because I don't really care if anybody's got normal color vision. I want to see if they have abnormal color vision. I want to see if they have acquired color vision defects. That's what we're going to spend the next 45 minutes talking about. So the first thing, let's get our facts right. In this left column here, you see all the little factoids that go with people that have acquired color vision defects. And by definition, I'm talking about some person that at one point had normal color vision, and then at some point after that had abnormal color vision. And then my job is to figure out why is that happening and is it important. That's my job. Well, the first thing you got to know is that this is not rare. So acquired color vision defects, some defect that an adult person is getting, it could be a kid, but usually an adult person, where they have normal color vision when they're 30, they have abnormal color vision when they're 50. Well, that happens to 15% of the population. It's not a small group. That's a big group. That's more people that have glaucoma. That's more people that have macular degeneration. I mean, it's a big deal, and you know, it's really shameful that we have not given it more attention up until now. Thank gosh we're giving it attention now, but it's really kind of pathetic when you think about all the people through the years that we may have been able to help clinically, and just because of lack of awareness and such, and to a degree lack of technology, which we've now solved, you know, we really couldn't address it like we are addressing it now. Remember that patients may not know that their color vision is different. Just like the person with 20/50 vision may think that everybody sees like that. The 6-year-old kid that's a -5, he thinks everybody can't see the leaves on trees. So they don't know that they can't see right. You got to test it. They can describe it in ambiguous terms. They can be all over the spectrum as far as what color defect is there. The one eye could be different than the other, so they could be asymmetric. And because they're acquired, they can change. So you can, and I'll talk about that in a little bit, how with certain types of conditions in particular, you can have one color vision defect at the beginning of the disease process, early in the natural history, and 6 or 12 months later, the defect could be totally different. So you've got to know these factoids about acquired color vision defects for any of this stuff to make sense, and for you to use the technology at its best, where you maximize the benefit to both you and your patients. So you've got to know these things. And then here, just a general listing. This could be called clinical indications. I've almost lost count of the number of doctors, whether it's this technology or any other technology that I talk about, but since we're talking about color vision testing, we'll be specific. Well, one of the most common questions will be, well, who can I do this test on? Or the more derisive way to say it, who can I run this test on, doc? Who can I run this on? you know, which is almost like, who can I make money on? You know, that's what they're saying. Well, I mean, I don't like to say it like that. So the clinical indications for extended color vision testing are anything on this list, okay? You guys have been looking at it as I'm talking, so I don't need to go through the detail. Let's keep going. One of the most, in our modern society, in our 2016 society, with the almost unlimited access to drugs, both legal and illegal, that we have, there's over 300 common drugs that can make someone's color vision change. I'm not going to read the list. Y'all can look at it later. But to say, you know, I'll have, when I'll talk to doctors about glaucoma, and they'll say, well, I don't need to buy a $50,000 laser scanner. None of my patients have glaucoma. Well, I'll talk to doctors now. Well, I don't need to buy a color vision testing machine. None of my patients have abnormal color vision. I'm like, okay, yeah, right, sure, that's what you say. But how many of your patients are taking one of these 300 drugs where they may have some clinically significant side effects? That's a whole different question there, maybe. So there's plenty of clinical indications when you blend this slide and that slide. Okay, there's plenty of patients where we might be able to identify color vision defects and make important decisions to help our patients. So there's plenty of clinical indications. How does someone get a color vision defect? What is the mechanism, the pathophysiology, or the pathogenesis of an acquired defect? So there's got to be some change or some damage to some component of the visual system. It could be prereceptor, which is almost always going to be the lens in the eye, some kind of cataract formation. It could be the receptor cells themselves. Remember, any disease that can cause damage to the macula, diabetes, macular degeneration, toxic maculopathy from plaque, when any of those things, you're going to have the structural damage is going to be at the level of the receptor cells. And then, of course, you can have post-receptor damage, which is from stroke and glaucoma and multiple sclerosis and concussion and all kind of other things that will damage parts of the brain. So anywhere in the three primary anatomical locations, prereceptor, receptor cells, post-receptor, damage in any of those areas can lead to an acquired color vision defect. And when you contrast that, and this is the only time I'm going to say these words in this course, genetic color vision defects. So in contrast to the genetic defects, which were always the same in each eye, you know, acquired defects can be different, and I've seen literally hundreds of them in the past 5 years that I've been doing extended color vision testing. You can have one eye normal, one eye with a tritan, you can have one eye with a tritan, one eye with a combination defect, dutan, pro. It's just, there's no rules. The only rules is there's no rules. So when you have a situation where it looks like the rules are not being followed, that tells you that you have an acquired color vision defect as opposed to a genetic defect that you would see on some little kid. So this is how people get it, and these are the three areas where the damage can occur, and it's our job as the doctor to figure out where it's happening and what we're going to do about it. The Color DX device isn't going to tell us that. We've got to do that, okay? So let's keep going. So now, hopefully, all the doctors listening either have acquired a Color DX device already, or they're extremely interested in getting one, so one or the other. So now you've got your instrument, you're ready to start testing a patient's color vision, and again, testing it, not screening it, not playing with it with some Ishihara plates that we bought 35 years ago and that was developed over 100 years ago. No, we're not going to do that. We're going to test it. I'm not going to screen it. I'm going to measure it. I'm going to see what's going on. So I'm going to do a diagnostic exam. What is the goal of the exam? Well, you see the bullets here. You know, that you got to get some clinical information. You want to differentiate what kind of defect is present, if there is one. You want to figure out if it's in one eye, if it's different in the two eyes. Does it come and go? And again, the probably most important thing is figure out what's causing it. You know, what's the disease or the condition that's producing the defect. And then once you figure that out, almost the easiest thing to do is then prescribe a treatment program. You know, kind of once you get to number 4, number 5 is a gimme. These are the ones where you got to do some work. So these are the goals of the exam. I mean, you got to have a method to the madness. You're not just doing this stuff just to be doing it. We're not doing it just to make money. We're not doing it to take up our staff's time. I'm doing this to see if there's something wrong with my patient, and if there's something wrong with him, is there anything I could do to make it better? That's what I'm doing it for, okay? So let's start talking about what can I do it for, doc? You know, so I'm going to give you my top list. Your list may be different. The list may be different in New York versus Texas. I don't think so. To me, Texas is Texas. You know, people are people. But this is my list in kind of the pecking order, and I saved the best for last in case anybody's looking ahead. So the first thing is the first type of patient, the first condition, the first group of people. You know, when I'm in my office, people are coming in all day. I'm seeing 40 patients a day. Somebody comes in, I'm thinking, okay, who am I going to do this test on? Who am I most likely to do this test on? Where would the information be most helpful? Well, the first group of people in my office is a bunch of old people. Luckily for me, I got a bunch of them. My practice is about 35% Medicare, fortunately. So I've got, you know, 5, 6, 8, 10 Medicare patients coming in every single day. And I know I'm not the only doctor like that because I've talked to docs that have signed up for this class, and I know they have practices like that too, probably while they're listening. So the first group of people is a bunch of older folks where they may or may not complain about their color vision changing. These things here, these little bullets, are why it's going to change. Either the pupil's getting smaller, the lens is yellowing up, the density changes, or you can actually get fallout of the cones, in the blue-yellow cones in particular. So these things are what can produce or what leads to the condition called the dyschromatopsia of aging. And dyschromatopsia is the correct term for a loss of color discrimination. And that is the correct term for a color vision defect or a color vision abnormality. So we can go dyschromatopsia, we can go loss of color discrimination, or we can just say color vision defect. You know, I'm trying to get the terminology right, so I keep putting it up here, because up until I started studying this stuff and doing it 5, 6 years ago, I never said the word dyschromatopsia, but I see it all the time now. Okay, so this is the dyschromatopsia of aging. And you would say, well, so what's the big deal? Why would who cares? You know, so what? Here's how I use the information in my medical decision making. So let's say it's tomorrow morning. I've got the 69-year-old lady coming in. I saw her a year and a half ago. She has mild to moderate cataracts. When I saw her a year and a half ago, she was best corrected 20/25 in one eye, 20/40 in the other. So she really wouldn't have met the Medicare criteria of medical necessity, but certainly blurred enough to where she would complain about it. We decided a year and a half ago that it wasn't bad enough to try to do surgery on that one eye. We got the best pair of glasses we could. I sent her on her way, said come back in a year. So now she comes back a year and a half later. She says, hey, I can't see good. I want to see better. Can you give me some new glasses to make me see better? That should sound familiar to practically all of us, okay? I refract the lady. She was 20/25 and now she went to 20/40, okay? Now a year and a half later, let's say she goes 20/30, 20/50. So each eye got one line worse. So now she's asking me, Dr. Thomas, what should I do? And I don't want to make the decision for her. That's the kind of doctor I am. So I'll say, well, have you had to start giving up stuff? Have you had to, you know, can you still drive? Can you still read? I'll go into the stuff that we all do. So let's say we go through that whole song and dance, and it comes down to where we're still kind of right in the middle, where she's not real sure if she wants to proceed with surgery. I'm not real sure if I want to recommend surgery. She's right at the edge. One eye really doesn't even meet the criteria. We can do it if we took the first one out, but you know, the second one's a little iffy. So what if I did all my tests trying to see if there's something wrong with her? I'll do a visual field, nerve scan, specular microscopy, topography map. I'll do all kind of stuff trying to see if there's anything else that could be causing a problem. Let's say everything else is normal. There's no field loss, the retina's good, macula's okay, everything's okay, and the decreased vision is absolutely positively from the increase in cataract formation. So now what if I did a color vision test on this lady and the color vision test was totally normal? Then I could say, Ms. Jones, I got to tell you, I got a little bit of good news here. Even though your vision's down a little bit, all your other tests are coming down good. Your visual acuity, excuse me. Even though your visual acuity is down a little bit, the other tests of visual function that we've done, visual field, color vision, ERG, those tests are all perfectly normal. So the only problem is the cataract. There's nothing else wrong with your eye. If you're okay with it, we can probably leave it alone and I'll just check you back in 6 months. So that would be one potential outcome, one potential recommendation based on a normal color vision test. The same exact patient, same exact circumstance, I do the color vision test. Let's say I've got a moderate tritan defect in the good eye and a severe combination tritan-dutan defect in the bad eye that's gone to 20/50. And so now I could say, Ms. Jones, hey, I tell you, even though your vision's down just a little bit, your color vision is way off. I mean, way off. And I don't know if you've noticed it yet because it's only in one eye, but it's definitely starting to affect your function on your color vision. I got to tell you, there's no reason we should really wait. I know the same thing's going to happen in that other eye. It's already starting to mess with you right now, even if you can't tell yet. Let's go ahead. Let's just get these cataracts out right now. Let's just get it done because I know it's going to get worse. In that particular patient, the color vision test was the determiner for my recommendation, and everything pivoted on the results of the color vision test, whether I'm going to recommend cataract surgery to this lady right now, yes or no. It's a big deal, and I'm telling you, I have done that dozens of times where I'll pivot where everything else is the same, and if the color vision is normal and they're not really aggressive on it, I'll say, hey, let's leave it alone. But if they're even if they're not aggressive, and the color vision is totally abnormal, I say, Ms. Jones, it's getting worse. It wasn't like this a year and a half ago. Let's just go ahead and get it fixed right now while one eye's still good, and let's just get it over with. Okay, doc, whatever you say. It changes everything in that kind of patient. So that's an example. All right, let's keep going. The second condition, this is one that a lot of us are familiar with, the dyschromatopsia of Plaquenil. I don't want to spend a lot of time on this because we're kind of sort of familiar with it, and it's one of the few conditions, I hate to say it, where when I would ask optometrists and ophthalmologists, hey, do you ever do any color vision tests? Well, yeah, I check my patients on Plaquenil sometimes. I go, okay, what about everybody else? Well, no, I didn't know you could do it for anybody else. I just thought it was for those people on Plaquenil. I'm like, okay, all right, okay. So clearly we all know that we can do color vision testing on patients that are taking Plaquenil. I put the little factoids in here just so you can have something, but I don't want to talk about this anymore. So we keep going. This is a big one here. I want to talk about this one a lot. The dyschromatopsia of diabetes. Now notice I did not say diabetic retinopathy. I said diabetes, okay? People with diabetes, people taking metformin, people taking insulin, people that do not have diabetic retinopathy. Okay, I'm talking about diabetes. And I think every optometrist and ophthalmologist listening to this thing tonight has a bunch of patients with diabetes in their practice because it is an epidemic in this country. And I can't go a day without 5 or 6 people coming in here with diabetes. One of the reasons I got interested in this stuff. So this is a test question. Chromatic visual disturbance in association with presumed hypoxia precedes diabetic retinopathy in 55% of patients. And this is not me making stuff up. It's from these guys down here. Investigative ophthalmology and visual science. Man, this is a bunch of Arvo geeks. They're usually pretty smart. Okay, I trust them. So I'm not going to go look up another article. This one's good enough for me. So what these guys are saying, because it's true, is that people with diabetes, because of all the manifestations of the diabetes, and my old patients, they'll say, Dr. Thomas, what's going on? I said, well, you heard how people say they got that poor circulation, they got that post-circulation? I said, that's what you got with this diabetes. You got post-circulation. So that post-circulation is really hypoxia, of course, when we're talking properly. So diabetic patients get hypoxia. That's what leads to all the neovascularization and everything. And what we now can see is that in a whole bunch of these people, the hypoxia, which previously had been subclinical, now can show up on an extended color vision test. And you can have people with diabetes with 20/20 vision and no complaints and no obvious retinopathy, and you do an extended adult color vision test on it, and they'll have all kind of stuff going on. I've seen it too many times. It's crazy. It is crazy. It's incredible. It's really eye-opening. So I test all of my diabetic patients to get a baseline, because even if they're normal, well, if they're normal when they're 55, I still want to know what they look like when they're 65. So I get, just like with any other, pathology, sometimes the baseline is important. If it was a glaucoma suspect, you would do a baseline visual field and an OCT scan and fundus photos. How come you can't do a baseline color vision test on a person with diabetes if you know that chromatic visual disturbance in association with presumed hypoxia precedes diabetic retinopathy in 55% of patients? Then it becomes real important. If you didn't know this and hadn't read this article, then none of it makes sense, and you're running around saying, hey, who can I do this test on? Okay, so here's a big old group of people that you could do the test on. And you would say, well, so what? Well, the so what, of course, is, let's say I've got that 50-year-old lady or that 40-year-old lady that's been diabetic for 6 years, and she's thinking everything's okay. She's checking her blood sugar fine, and she's thinking she's fine. And I say, well, you look okay, your vision's clear, but there's things that could be going on that won't show up either with me looking at you with an ophthalmoscope or you doing a visual acuity test. Do you mind if I get a little bit more information on you, and let's make sure that there's nothing wrong? Okay, doc, whatever you say. Okay, then I go to town. And if you go to town like this, you're going to see stuff because the stats say it's more than 50% of the people. And then if I see the positive finding, then I go into my regular optometrist mode. You know, optometrists have the time to talk to our patients, okay, because we're supposedly not busy. We give personal service. So we go into that whole song and dance where we go into the diabetes management, diet, exercise, medicine, explaining how the three work together. So, you know, you could have a lady or a man, of course, where you would have that conversation and say, Ms. Jones, hey, I know you think you're okay. I know your blood sugar seems like it's fine, but you've been diabetic for 7 years and it's starting to catch up with you. And all of us that keep up with this stuff know it's really not the level of control of the diabetes that causes the problem. It's the time of the disease. How long have you had the diabetes? The longer you've had it, the more likely you are to have complications. Not if you got diabetes last week and your blood sugar is 600. Yeah, you might fall out, but you're not going to get diabetic retinopathy and hypoxia and all this other stuff. That's all time related. So then you would talk to that patient about modifying one of those three things, diet, exercise, medicine, while you still have most of your test results being good, and let's try to get the rest of them better. So it would change the whole case presentation on that supposedly normal lady with 20/20 acuity and no apparent diabetic retinopathy if her color vision test was abnormal. Wow, that's a big deal. Man, that's a big deal. Okay, there's plenty of patients to perform an extended color vision test on if you know the facts. The second bullet here would be people that still may not have obvious retinopathy, and I used to see these and didn't know what I was looking at. That's why I put this image up here. I figured it out about 8 years ago. I didn't have a clue what I was looking at. Sometimes you'll see people with diabetes and you do an OCT scan and it's all red like this, and then you look at all the overlays and stuff and they look like this. I've seen this simply dozens and dozens of times, and in years back I didn't know what I was looking at. You know, there was no OCT class when I went to optometry school. Nobody taught us this stuff. It's not in review of optometry right now. So what you're seeing here is retinal atrophy from the diabetes secondary to presumed hypoxia. If I'd have took a fundus photograph of this patient, there's no hemorrhaging, there's no dot blot hemorrhages, there's no macular edema, there's none of that stuff. She looks fine till I did this OCT scan, until I did a color vision test. Oh, then that's totally abnormal. So the moral to this story is if you got a person with diabetes, they got 20/20 acuity, hey, good for them. Great, I don't care. I'm doing an OCT scan, I'm doing an extended color vision test, and if any of them is even remotely abnormal, then I'm doing a visual field and an ERG, because now I'm on to something, and that person might not be quite as healthy as they thought or as I thought. Look at this. 55 to 65% of people with retinopathy have color vision defects. It's outrageous. How come we wouldn't do a color vision test on these people just like we do the OCT scan? How come somebody comes in, they got diabetic retinopathy, we do an OCT scan and call it a day? Oh, that's all we need. We don't need anything else. We can do a structural evaluation. She doesn't have any macular edema. She's okay. Just let it go. Okay, fine. No, that's not fine. Okay, you're not done yet. But you got to know the facts. So if you know the facts, you're not done yet. And the color vision test is part of the armamentarium. It's part of the protocol. It's so easy and so important and so valuable when you understand what you're looking at and what the information means and how you factor it into your decision making. And look here, this last bullet about blue-yellow deficiency is found in 90% of people with diabetic retinopathy. Wow, 90%. I wonder if that has something to do with this. Where if you get you a hangnail in there, you're going to start losing half of your cones connected with the blue-yellow color vision. Almost every disease that affects color vision produces a blue-yellow defect way more often than any other defect because of that. So you're always looking for blue-yellow, always looking for blue-yellow. Blue-yellow is the key with ocular pathology. And tests or devices that don't test for blue-yellow, like Ishihara plates, are essentially worthless to medically oriented optometrists or ophthalmologists like us. It's just nonsense. So just those things are paperweights. So just throw them away. So let's keep going. Let's talk about optic neuritis for just a second. Not a real common thing, and the only reason I put it in here because when I still kept my note service from 35 years ago at U of H, and every once in a while I still look through it, and there was like 3 pages of color vision testing in 4 years in my note service, and 2.5 of those pages were talking about optic neuritis. So I mean, we've come quite a long way, but since that was the only thing we actually got trained on, I thought I would stick it in here. So optic neuritis, demyelinating event, usually MS. Okay, you guys can read the slides. I'm not going to read the slides to you. Yeah, the only other thing here, other clinical signs include pain, pupil stuff, decreased color vision. Okay, we all learned that. Okay, so optic neuritis. So there is a dyschromatopsia of optic neuritis, except that it has no pattern. See, I looked at all my stuff. Y'all remember that Kohler's rule, all that nonsense we learned in optometry school? Some guy named Kohler from back in the 1800s, figuring out color vision tests, and they were still teaching that stuff as recently as the 1980s. Okay, like if it was an optic nerve problem, it was red-green. If it was something else, it was blue-yellow, and there was no in between. Okay, total nonsense. So there's no single type of color vision defect associated with optic neuritis. You see, again, you guys can read the slides. The biggest deal here, defects, this is one of the conditions where, in particular, the defects change over time. And what you'll see is that the red-green defect was most common in the beginning, and then it changed, and then it went back. It could go up and down. There's just no rules at all about optic neuritis. Here's the thing I want you to see. This study done by these guys here, this Indian Journal of Ophthalmology, and I tried to look for stuff that's recent. I mean, so you got a study that's 3 years old, okay? It's not 100 years old, it's not 20 years old. I mean, it's a recent study, okay? And what these guys found out is that you got people with MS, so we're talking about multiple sclerosis. I've got probably, 20, 25 patients with MS. I mean, it happens. Color vision testing had the most value in detecting subclinical visual pathway involvement. So you got people with, this is just like the diabetes patient I was just talking about. So you got people with optic neuritis, they got a history of without a history of optic neuritis, but they do have MS. So they got MS, they have no history of optic neuritis, they got 20/20 vision. So you're thinking these people have had no effect on their visual pathway from the MS. They've escaped, because, just because you have MS doesn't mean that it messes up your optic nerve. It's not guaranteed. Well, what these guys discovered is that 70% of the people that had MS with no history of optic neuritis and 20/20 acuity had dyschromatopsia. 70%. 55% had abnormal VEPs, and only 30% had structural damage that you can measure on an OCT. The most value was the color vision test. And I thought that was kind of important to know. All right, let's keep going. So let's close it out with the big bugaboo, glaucoma. Okay, now I got a bunch of glaucoma patients. I know everybody does not, but I do, and I know there's people listening here that do have lots of glaucoma patients. Again, there's no one category for me. You see, I mean, if you're coming in and you got anything, you might be a candidate to have a color vision test in my office. But the most common would be glaucoma patients, glaucoma suspect patients, patients with cataracts, patients with diabetes, patients with diabetic retinopathy, patients with macular degeneration, patients taking Plaquenil. Man, that's almost like a bunch of patients. Okay, there's plenty of patients to run color vision test on and get valuable information. So let's talk about glaucoma. So again, everybody knows what glaucoma is. I'm not going to read the definition, but the key thing here, associated with changes in visual function. Y'all see that. Functional change can be a disturbance of any of these things. It's not just visual field, it's not a VP, it's everything. And one test is not more important than another. Who said that the visual field is more important than the color vision? The only reason the visual field is more important than the color vision is because somebody said it, not because it is. And the only reason they said it is because the visual field testing technology was more advanced than using an anomaliscope or a bunch of plates that didn't tell you anything. Now that the technology is advanced, like with a color DX, and you've got modern technology, just like you've got modern visual field technology and modern VEP technology and modern ERG technology, now that we got modern color vision technology, to me, these things are all the same. This ain't no more important than that. This one's no more important than this one. As a matter of fact, most of the studies we have available now shows that this one's the least important because it happens the latest in the natural history of the disease. And if you're waiting on a visual field to diagnose glaucoma, the person's going to be half blind 50% of the time. So to say that the color vision is some kind of ancillary or extra or superficial test, or you're just doing it to make money, absolute nonsense, okay? Nonsense. So we got the natural history of glaucoma that now shows clearly, and we've known this for about 10 years, glaucoma is not an eye disease. It's a disease that damages the eye, but glaucoma is a pathology in which brain structures are damaged too. Or how could we pick it up with a VEP if it wasn't messing with brain stuff? And so you've got all kind of studies now. Wow, look, progress in brain research. This is not Craig Thomas making it up. It's all these guys here. So you've got all these facts and these indications that says glaucoma is a brain disease. Okay, glaucoma is a brain disease. We've already talked about the neural response of the visual pathway, not the eyeball. So it's the whole thing. So now we're going to talk about measuring stuff, measuring structure and function. This slide is kind of specific for glaucoma, but this stuff is all interchangeable and applicable to practically any other disease that we diagnose and treat. And again, if I bolded a thing in a slide, it's like a test question. So we got clinical measurements are attempts to quantify the integrity. That's the term. We're going to quantify the integrity of the anatomical neural pathways subserving vision. That's what you're getting ready to do when you perform that extended color vision test. You're quantifying the integrity of the anatomical neural pathways subserving vision. Man, that's kind of a big deal when you put it like that. Man, it's almost like we're doing something. This is serious. Okay, this is real. Now, this is a factoid that is specific for glaucoma coming out of this journal, Clinical Experimental Ophthalmology. But in my clinical experience, which is 33 years and probably 50,000 patients, this stuff is the truth for most of the other conditions that we see. It would be true for diabetes. It would be true for other stuff. So the key thing here, because again, when I've taught the docs where they would do a color vision test, and then for some reason they repeat it in a month and it's not the same. And then they'll go crazy and say, well, this thing doesn't work right. This isn't accurate. I want to send it back. I want my money back. It's not the same. Okay, stop it, okay? It's like a visual field. It's a subjective psychophysical test of visual function. It might not be the same, even if the person's the same. And if they got anything wrong with them, especially if it's glaucoma, the test results can exhibit a wide variability, even on repeated measurements, so you really don't know what's happening until you do a bunch of stuff. And the more tests you do, the better idea you got what's happening. The more you can double check stuff, the better idea you got what's happening. As a matter of fact, even though we're not talking about VEPs, what the VEP standards are from ICEV, the governing body for electrodiagnostics, is that if you're trying to figure out if somebody got something wrong with them and you do a VEP test and the first VEP test is abnormal, the protocol is to repeat the test to make sure it's consistent before you start making decisions. So most of us that understand this knows you don't have to get the same result every time. I mean, it's nice if you do. It's nice if you have consistency and repeatability. I mean, that's best. But if you don't, it's not like it ain't working, okay? So you have to understand the nuances, the ups and downs, the ins and outs of measuring structure and function. And of course, the color vision is function when we're trying to see if somebody has something wrong with them. So again, and specifically for glaucoma, so we got structural changes that occur in glaucoma, these bullets here, progressive loss of the cells, enlargement of the cup, so on. Functional deficits, well, we know you can get visual field defects. We know you can get VEP goofy stuff. You know that ERGs can get abnormal. Obviously, the pupils can get different if the glaucoma is asymmetric. Some people get glaucoma equally in both eyes at the same time. Some, usually it's not, but sometimes it is. And of course, last but not least, the loss of chromatic discrimination. So these are all the bad things. This is how you can lose vision. I could have put another bullet here, loss of visual acuity, okay? But that really falls under visual field defect. The loss of visual acuity, going from 2020 to 2050, that is a type of visual field defect. It's a central visual field defect. I use that code often, and it generates lots of tests because it is the correct way to use it. So loss of acuity would technically be right here. But you see, again, who says one of these is more or less important than the other? To me, they are all the same, and they're all equally important, and I do them all the time. So let's continue with structure function. Let's kind of close this thing out. So we got progressive glaucoma. You know, you've got to really, glaucoma is the thing that's been studied the most. So again, that's why I'm using the example. So you got in progressive glaucoma, you have a structure-function relationship between optic disc cupping and the visual field. And for most people, you kind of see it as the cup gets bigger. The cup will get bigger, but the field will stay the same. And then there comes a point where the damage kind of reaches, it goes past the kind of the critical point, and then they start to lose their visual field. So there's a functional latency period where the eye keeps getting damaged, the nerve keeps getting messed up, but the visual field stays the same. And then once you go past 0.6, then the visual field starts going down way fast, and it's kind of a curvilinear relationship. It's not a linear relationship. So the functional latency period, I'm reading ahead of my own self, indicates a curvilinear structure and function. Now, that's for glaucoma. And again, we're still for glaucoma. But when I was looking at this, I'm like, so what about the nature of the structure-function relationships between optic disc cupping and other tests of function? What about, so what if the cup gets bigger, does the VEP change? Does the ERG change? What happens to the color vision? Is there a pattern? You know, is it like the visual field where as the nerve kind of is mildly damaged, the color vision is the same and then it changes? Who knows? Okay, I don't know, not yet. I'm trying to figure it out. But you see, these questions are quite interesting. They are to me. So now last, let's talk about the disc chromatopsia of glaucoma, because of course there is such a thing. And what these guys figured out here in the British Journal of Ophthalmology, not Craig Thomas, you know, the British Journal of Ophthalmology says that color vision defects may precede visual field loss in patients with glaucoma. Wow, man, that's a big deal. I guess if you're waiting on that perimeter to tell you if they're losing their vision, they might be half blind. It's almost like I said that. Okay, maybe we need to do other tests too, especially if you know the facts that color vision defects may precede field loss in patients with glaucoma, and that a whole bunch of people with glaucoma lose some of their color vision. Now, it's not everybody. So, I mean, you know, it's 20-30%. So that means, you know, 60-70%, 30-80%, they may not. But still, that's important. It's important to know. So let's finish it off with this case report and kind of bring it on home and make it make sense. You know, we got to get clinical. So this is, you know, this is a real patient of mine, a guy I saw last year, a 62-year-old black guy, and he just came in because his wife made him come. His wife's a patient of mine. They had VSP insurance. She said, "Go get your eyes checked." That's why the guy came. He's, you know, he's the prototype for going blind to me. So you got a 62-year-old black guy that can actually see. Okay, it's the worst combination it could be because he doesn't go to the eye doctor. He's wearing, you know, +2 glasses from CVS for $10. He never goes to the eye doctor. Okay, yeah, he's the kind of guy that gets glaucoma and goes blind and then says, what happened? Well, that was what was getting ready to happen here. So the guy comes in, I examine him. When I shook his hand, I knew he was a glaucoma suspect because my staff had already checked his pressure. So as soon as I walked in the room, I saw that he had pressures of 29 and 26. So even though I did a refraction, because that's what he came in for, I mean, 2 seconds in, I'm wondering if this guy has glaucoma or not. So as soon as I finished the refraction, I started my workup. So my first test always, no matter what, always is an OCT scan. You see the OCT scan here. Again, look at the guy's pressure, 29 in the right, 26 in the left. OCT scan, pretty normal here on this right eye. You got this one little tiny, shallow, maybe wedge defect right there at 11 o'clock. Excuse me, you can see it kind of sort of right there on the sector plots right here. You see the left eye has more pronounced defect. You know, it's got a red down here on the sector plot. So, you know, you got asymmetry, you got clinically significant asymmetry, but clearly this guy's retina is not blowed up. It's not terrible. It's not like he's got some out of control advanced glaucoma, but it's not normal either, and it is asymmetric. So my first test is not normal. You have a mild loss of retinal ganglion cells. That's what we're seeing there. Since I got the guy sitting there at the OCT, and we started doing this 3-4 years ago, I don't even know why it took me that long. When we sit someone down at the machine, we just do both scans. I don't even care. It takes 5 minutes. I ain't doing it. It don't mean nothing to me. The information is so valuable. So whenever we do a nerve scan, we go ahead and do the macula. If I got someone there doing a macula scan, we go ahead and do the nerve. Okay, I just want to they're sitting there, just do it. Well, we did the macula scan, and lo and behold, look at this. This guy's not diabetic. I've seen this dozens and dozens of times. So, and again, he's plano, so this is not like he's got a -10 and some real thin retina or something. This is glaucomatous atrophy. That's what this is. Again, I didn't used to know what this was, you know, until a few years ago, but I recognize it now. So you've got a thin retina in a person that's only 62 and is not diabetic or has no other systemic conditions that would lead to this kind of condition. So to me, your macula scan is showing abnormality. Everybody's big on the ganglion cell now. Well, here it is. Ganglion cell's abnormal on both eyes. There's the right and left showing more involvement. Okay, so I mean, clearly I'm on to something. Now, it may not be glaucoma, but I'm on to something. The fact that the pressures are high tells me it's probably glaucoma. So I keep going. I do a visual field test. Did a 24/2 field. You see this guy was here. This was August of 2015, so it's less than a year. To me, this left eye is totally normal. I don't see nothing. The right eye, maybe, so I put this little asterisk right here. You see maybe something right there, maybe. That kind of maybe a nasal steps, I don't know. But you got low reliability, low test reliability. So maybe this was a learning curve. Maybe he didn't figure that out. If this is real, it would have to be from that. And I don't think so. Because then this one that looks much worse would be producing a defect. I don't see it. So I put no definite glaucomatous visual field defect, but I do recognize a different doctor may say that that's an early defect and perhaps have a contradiction there. But clearly the guy's not going blind. I did my color vision test. Okay, did an extended color vision test on the guy. Mild tritan defect. Mild tritan defect. Now, if you look at the hue circle, the D15, I just do that just for show, just to kind of show the patient. This is what I'm looking at, and this is what I'm looking at. And this is actually an old printout. Again, I did this guy last summer. The software has been updated. There's 2 or 3 more lines of information on here now. All you guys that have new ones probably already see that. But it doesn't matter. Here, mild tritan, mild tritan. And again, this is the same, this looks the same, pressures are within 3 millimeters of each other. So this guy, if he has glaucoma, it does not appear to be asymmetric. So I get this mild tritan defect in both eyes where you have essentially normal visual fields. Wow. Maybe this is a guy that has a color vision defect preceding the visual field defect, almost like the guys from the British Journal of Ophthalmology said. So then I do a VEP test on my slick KONAN Evoke DX, and the test results are abnormal. I'm not going to go into interpreting the test right now. If you guys have one, you know what you're looking at. Suffice it to say, both eyes are abnormal. So we've got our very sensitive, highly sophisticated IC-VEP testing telling me there's abnormality on both eyes, just like the color vision test said there's abnormality on both eyes. The visual field, if you blow that off, says there's no abnormality anywhere. The OCT says there's something going on, but it's asymmetric. And of course, the guy's got highly suspicious pressures. Okay, I'm finding too much stuff going on here. So I review all of my tests, review all of the diagnostic test results. So I've got my OCT scan saying that he's got mild loss of ganglion cells. He's got high pressures, abnormal VEP, abnormal OCT, abnormal color vision, normal fields, and I did a rapid X on him. He had normal pupils. I'm not surprised. The glaucoma appears to be symmetric. It would only show up on the pupil testing if it was asymmetric, and I actually did do gonioscopy on the guy because his pressures were high and his angles were open. So I diagnosed primary open-angle glaucoma and put him on drops that day. I didn't wait. I didn't come back. It's not necessary. The guy has glaucoma. I got 1, 2, 3, 4, 5 things telling me there's something wrong with him. I don't need 6. I can work with 5. I got 5 things telling me that this guy has glaucoma. Hey, he has glaucoma. Okay, I'm done. So this is how I reported the visit. You can report it any way you want. I mean, you can do what you want. This is how I did it. So I did a comprehensive exam. He came in with that VSP. I tossed that aside like toilet tissue. It means nothing. He had some Blue Cross insurance. That's what I filed the visit on. So the visit is 9204, open angle glaucoma. Now I didn't know this when he came in, and I'm not going to, I don't even want to hear it right now. We'll talk about that in another lecture. If he came in on his VSP and all that, just to forget that nonsense. Okay. So I built a comprehensive exam. He had glaucoma. These fees are examples, no collusion. You charge what you want. You charge $10, you charge $1,000. I don't care. These are close to my Medicare allowables. That's why I put them up here to where we give you a reasonable idea of what you could expect. But your fee is your fee. I don't care what your fee is. I took some fundus photos. You saw the images in the first slide. Even though I did the OCT, we all know you're not going to bill them both the same day. You're going to start with the photos because it pays more. There you go. Same diagnosis, open-angle glaucoma. I did my field, same diagnosis. This guy, I used this column here just if the patient had Medicare insurance. If he had Medicare insurance, you would put these 5-1 modifiers on these two service lines. If he had Blue Cross or Aetna or Cigna, you wouldn't have to worry about that stuff. So it's just Medicare. Color vision test. And here, this diagnosis code could be practically anything. First of all, there's no rules on color vision testing. I found one LCD, one local coverage determination from a Medicaid carrier here in Texas. It is the only LCD I have found in the entire country on extended color vision testing, and it covers, 800,000 people in the whole country. So essentially, from what I can see, and I have looked, there are no rules. So as long as you do things the right way, the appropriate way, follow standard of care, maintain your ethics and your integrity, you're not going to have any problem at all either reporting this service or getting paid for this service because there's no rules. So even though I put open-angle glaucoma, mild stage, I could have put acquired color vision defect because that's what he has. Okay, that is not you got a 62-year-old black man. You think that guy has a congenital tritan defect from when he was 5 years old that he was born with? No way, okay? That's an acquired defect. That's what he has. It's an acquired tritan defect. So I could have put H5 2.53 acquired color vision defect. I could have put it right there. Blue Cross would have paid it. I could put open-angle glaucoma. Blue Cross would pay it. I could have put visual field defect. Blue Cross would pay it. I could put glaucomatous optic atrophy, which is what you have to use for the VEP test because they won't pay for a glaucoma code, and Blue Cross would have paid it. I could put almost anything but hangnail, and they would pay for a color vision test. And so when doctors keep asking me, well, how do you bill it? How are you going to get paid? I'm like, man, please stop it. Stop it. Just stop it, okay? Just do what you need to do to take care of the patient, and whenever you find out is wrong with them, then that's the code. That could be cataract. That could be cortical cataract. It could be nuclear cataract. It could be visual disturbance. It could be practically anything, and you would generate that test. So this is how I reported the service, okay? So you see that. Documentation requirements. Basically, you got to prove that the test is real. Okay, that's not too hard. And this test does require an interpretation and report. And I've had docs ask me many times, what separates an extended color vision test where you actually can bill it with this procedure code and some kind of lame screening test like the Ishihara plates or the HRR plates or some other stuff like that? Here's the deal. It's two things. It's these two things. So the test has to tell you the type of the color deficiency, and it has to tell you the severity. It's got to have the severity. All of the tests we use tell the type. Hardly any of them tell you the severity. If you don't have a severity quotient in there, you can't bill it as an extended color vision test. And so on your Color DX printout, where it says mild tritan, see, it could say severe tritan. It could say moderate tritan. But it's got to have an adjective in front of it, or you're not billing it as an extended test, okay? So your documentation requirements, tritan, mild. Boom, you're there, okay? You're done. You have now met the documentation requirements, in a minimal sense for reporting this service. And of course, if you've done previous tests, you got to compare them. And most importantly, how you're going to use the information to make a decision. And I've already told you an example of how to do that. We've only got an hour. It's almost done, so I can't get into heavy detail. But everybody here is smart. You can take what I just said and just extrapolate it out to all of your patients with different conditions. You've got coding guidelines. It is a bilateral test. You put a unit of 1. There's no bundles. There's no exclusions. So you can do any other test on the same day. It doesn't matter. You can do an exam. Who cares? There's nothing. It means nothing. The only limitation, and again, this is just a few state Medicaid plans. Some of the Medicaid plans don't pay this test because unfortunately we've had knucklehead doctors out there that abused it, and they were doing this test on every little kid they saw, and the states just got tired of paying for it and they cut it off. And so they've abused us all because some guys can't follow the rules. But that's why some Medicaid plans don't pay it. That's got nothing to do with the validity of the test. The test was being abused. Utilization guidelines, there's no rules. Now you can't be stupid. I mean, I'm not going to do this test every day or once a week or anything like that, but I might do it every 6 months. If the patient came in and their vision was changing, I could do it every month, every 4 months. I could, whenever it's reasonable and medically necessary. How often would you do a visual field? How often would you do an ERG? You know, just it's the same thing. This test is no different. And if there are no rules, and there are none, then you just follow these guidelines from Medicare, which states they should meet standard of care. So if the way I run tests is the way you should run tests, okay, that's kind of the way it is. So pretty easy rules to follow. Nobody's going down for doing too many color vision tests, okay? So those are utilization guidelines. Just don't be stupid, and you can do the thing as often as you need to take care of your patient. And in conclusion, when we combine structural and functional testing, it will improve our ability to diagnose glaucoma, like I just said on this guy. Because again, imagine if this guy, so imagine what if the VEP test was normal? So what if I had one abnormal, and then one abnormal here? Would that be enough? Would you prescribe medicine with 2 things or 3 things? To me, 2 is my minimum, and they better be real bad. 3 I'm much more comfortable with. 4 I'm pretty easy going. 5 it's a slam dunk, and I'm like, where's my next patient? I got to go. Okay, I'm not even thinking about it. This guy had 5. Hey man, take some Travitan. I'll see you in 3 weeks. Get out of here. Okay, so easy. It's so easy. So in our conclusion, you got to combine your test. When you combine all the tests, so it's not, the visual field isn't more important than the color vision. The color vision is not more important than the VEP. You combine them and they're all the same. And then you combine them and then you make your decision. And then you use the measurements from one domain, and the domain is either structure or function, to support the interpretation of the other. And every patient is different. Every test can be different. And if you get goofy results, it ain't the end of the world. It doesn't mean that the machine doesn't work right. You got to understand that every patient is different. Every test result can be different. And in particular with glaucoma, there's no rules at all. And so simply the more information you have, the better. So that's my conclusion. Now, I know I talked fast. We went for 55 minutes. I got a lot of information out. I'm hoping everybody now is just a little bit more comfortable with how you would use your device, the benefits you can get from it, the information you can get from it, how important it is. If you don't have one, you ought to get one tonight. You know, every day you go without one, you're not rendering and delivering the type of quality care that you can. It's not about the money. It's about you being a better doctor. And what I've learned in 33 years is the better doctor I am, the more money I make. They go together. So I got no problem with it. I'm trying to be a real good doctor. That's what I'm trying to do.